Good morning, everyone. Thank you for being here and welcome to our workshop, The Best Abstracts in GI. I am Nicole Green. I'm a pediatric gastroenterologist at Seattle Children's Hospital and the University of Washington. And my co-chair for this session is Dr. Michael Wilchansky at Hadassah Medical Center in Jerusalem in Israel, who obviously, given the state of affairs right now in Israel, was unable to travel, but luckily we have him joining us over Zoom. So he will give an introduction to the session. In terms of how the session will run, we have 5 speakers, and there will be opportunities for questions after each individual talk. So you can either come up to one of the microphones in the aisle, or if you are using the app, you can type a question in the app under our session, and I'll be able to see that. So with that, I will turn over to Dr. Wilchansky.
Good morning. I hope you can see my slides. Thank you very, very much, Nicole. Welcome to session W12. Really, this should be called the best abstracts of the whole meeting, in my opinion. And I want to give special thanks to the foundation for enabling me to chair this session from my home in Jerusalem, Israel. And also thanks to my co-chair, Nicole, for putting up with all this. So just a few words of introduction. We're going to have some great talks this morning. We're starting off with some basic science and going to some clinical studies. And I just want to, if I can just move my slides. Whoops. Yes, okay. So the first talk will be from Kate Weston from Cleveland, Ohio. And it's the role of CFTR in the small intestine and the impact on epithelium and gene expression. We know that obviously the new therapies, we don't know enough about the gastrointestinal manifestations. And the CF mouse model is a great model over many, many years to look at the GI manifestations. And of course, there have been many articles about the intestinal inflammation and with laxatives and obstruction, which we see in the CF mice. And this abstract will be about a diet for the CF mice and looking at the effects of that. And that will be the first talk. And then we're going to have a talk from National Jewish Denver, Colorado, and the effect of modulator therapy on metabolic pathways and treatments. And for this, we know that there are using metabolomics, which is a novel way of looking at the effect of the modulator therapy before and after, and looking at the different metabolites in relation to lung function, relation to hospitalizations, and so this will be looking at clinical outcomes following treatment. And our third talk comes from the Hospital for Sick Children, Toronto, Canada, and this looks at the relationship between inflammation of the lower intestine, abdominal pain, and polyps in CF. And we know that abdominal pain is very common, and in most studies, 60% of our patients complain of abdominal pain. And we know that in the past, intestinal inflammation has been looked at, especially using fecal calprotectin, and the objective of this study we're going to hear is to look at the association of inflammation of the intestine and abdominal pain using fecal calprotectin and histology and the presence of intestinal polyps. This is a prospective study, and we're looking forward to hearing that soon. And the fourth presentation will also come from Canada's BC Children's in Vancouver, and they looked at the relationship between low intestinal inflammation and looking at the exocrine pancreatic insufficiency and deficiency. And here we're looking at one center experience of the what happens to the exocrine pancreas with modulator therapy. It was a retrospective shot review and looking at all parameters, including growth and nutrition, before and after, and see what occurs to the exocrine pancreas on CFTR modulator therapy, another very big open subject in CF research. And finally, we're going to look at the ethnicity, the effect of ethnicity on GI and hepatic complications in CF. And this is a study from Children's Hospital of Colorado. And we know that CF is, of course, we know, associated with GI liver disease. And there are some ethnic groups who have more severe pulmonary disease. This is known to be Hispanic people with CF have more severe pulmonary disease. And this was a study looking at the prevalence of early and late growth, nutrition support, and liver function enzymes and markers in this population in a large pediatric CF center. So these are the 5 talks we're getting here today. It really was a pleasure and honor choosing these talks for this session. And I hope the room is full, but I can't see it from here. And I want to hand back now to Nicole, who will introduce the speakers. Thank you very much.
Thank you, Michael. Quick AV request. Can we dim the lights a little bit slightly? Apparently there's some glare on the screen, but we will do our best. So with that, I would like to introduce our first speaker, Dr. Aura Perez. She is a research scientist at the Department of Genetics and Genome Sciences, School of Medicine, Case Western Reserve University. I'll pull up your stuff.
Good morning. First, I would like to thank Nicole and Michael for inviting me to speak at this workshop this morning. I have nothing to disclose. Therapies developed in recent years have increased the life expectancy of the CF patient, but they seem to have limited efficacy in the gastrointestinal manifestation observed in the CF patient. Therefore, understanding how the action of CFTR from the intestinal epithelia contributes to this GI manifestation is important. The CF mouse models recapitulate those GI disturbances without the confounding effect of pancreatic insufficiency. Therefore, they are a good model to study GI disturbances in CF. Because the intestinal obstruction that we see in CF occurs in the later part of the intestine, research has been focused on mainly in the ileum. And traditionally, laxatives like colloid have been used to alleviate that obstruction in our CF mice and improve survival. In our efforts to find a diet that was nutritionally for our CF mice, we found a diet that improved survival of the mice without the use of laxative. So we were interested in investigating why this diet did not require the use of laxative. Our initial goals were to examine the effect of diet, genotype, and sex throughout the whole small intestine, not just ileum, both at the histology and the gene expression level. And for that, we used 3 genotypes: a wild-type mouse, a CF mouse that carries the most common nonsense mutation, the G542X, and a CF mouse whose CFTR has been restored in the intestinal epithelium. Our approach consisted of introducing both males and females mice at weaning to either the chow diet plus cholide or the protective diet without cholide, and mice were euthanized at 6-8 weeks of age. The sample preparation was as follows. For histology, we cut the small intestine from the stomach to the cecum in either 5 or 4 segments, and Swiss rolls were prepared from each one. For RNA-seq, RNA was extracted from 3 inches at the beginning, middle, at the end of the small intestine. From the Swiss rolls, 5 micrometer slice sections were prepared, and they were stained with either hematoxylin and eosin so that we can manually measure the villi and crypt height as well as the smooth muscle layer thickness. They were also stained with either Alcian blue or PAS so that we're able to count the cells containing either acidic or neutral mucin respectively using the mathematical model STARDIS in QPath. The RNA was sequenced in the Illumina platform, and the reads map to the mouse genome. This is a representative slide for both a wild type and a CF mouse of one of those last rolls. In any case, for all of the rolls, they were prepared that the inside of the roll was the section closest to the stomach for whatever that roll, and the outside of the roll was the section closest to the cecum. I have indicated the circular and longitudinal layer as well as the villi and crypts for both mice. The measurements were done as follows. Each roll was divided in 6 equal sections, and in every case, only intact villi and crypt units were measured, or places where we could identify both circular and muscle layer. For the villi and crypts, only the outside layer of each roll was measured. For the smooth muscle layer, we began measuring at the inner side of the roll, the part that touches one of the axes, and kept measuring every time that we touch one of those axes until we completed one round, and then the second round, and so on and so forth. This is a representative slide of the same, I'm sorry, I keep changing it. This is a representative slide of the same roll stained with either acidic Alcian blue or PAS to look at acidic and neutral mucins for both the wild type and the G542X. In all of our results, sex did not make a difference, so the sex was combined for everything that you're going to see now, but in every case I indicated how many were male and how many were female. This is the effect of our villi and crypt length measurement. The top 2 panels indicate the protective diet, the bottom 2, the diet with cholide. Black dots represent the villi with their corresponding crypts in red. And you can see for the wild type in both diets, there is pretty fairly, the same level of length of the crypts along the whole small intestine. But when we look at the CF mice, both diets show an increase in the crypt height along the entire length of the small intestine. This is the same slide that I just showed you, but now shown as an average. I just wanted you to see the individual points in the other one. From now on, all of the data is going to be present as an average, and if you want to see the individual points, you just go to poster 530. And again, just to recapitulate, you can definitely see that both diets cause an increase along the entire length of the small intestine in the length of the crypts. This is the summary of the smooth muscle width, and in this case, the black represents the circular layer and the red the longitudinal layer. The CF mice have, in this case, a gradual increase of both layers that begins to be more prominent in the middle of the intestine, and is definitely way more at the end of closest to the ileum, and both diets show the same phenomenon. These changes, both in crypt height and muscle layer increase was present as early as 21 days old. These mice came from a mother that was fed the protective diet as soon as conception was observed. And you can see that both the cribs as well as the smooth muscle layers are both increased in the CF mice. And what is more telling, the mice that were a CF mouse where CFTR has been restored to the wild type for the intestinal epithelium, those mice look exactly like wild type. So there is no change in crib length or no change in the increase in the circular layer. Now we look at the mucin staining, and we did find now a difference in the diets. I'm going to begin with the two bottom panels. That's the diet with coli. In this case, the one thing, it doesn't matter diet, genotype, sex, or what. We saw what we expected to see, an increase in the number of mucins as you go along the small intestine. But the diet with coli, there is no difference in the amount of mucin, either neutral or acidic, between wild type and CF. But there is a significant, much more mucin containing cells in both acidic and neutral flavor in the CF versus the wild type. And the acidic mucin is the preferred, the one more frequent present. This was also observed in our younger mice, but because now we have less number of mice, they are not statistically significant, but they are definitely more both acidic and neutral mucins present in the younger mice. And this again was not present in a CF mouse where CFTR has been restored to the intestine. If anything else, the neutral mucins were slightly less in the CF mouse. We then went to examine what happened to gene expression in mice that were fed the protective diet. And now you can see now the duodenum and jejunum, the number of mice analyzed is indicated in parentheses. There were thousands of genes that were differentially expressed between the CF mouse and wild type, both the duodenum and jejunum. And to check to see if that was just because CFTR was not present in the intestine or because signals coming from the outside of the intestine, we created yet one more model, a mouse that is a wild type, but that CFTR has been disrupted just in the intestinal epithelia. And this mouse, you can see, have also thousands of genes differentially expressed from CF in comparison with the wild type. The mouse that is a CF mouse, but whose intestine was normal, was wild type, have very few genes significantly different between wild type and CF. So taking CF either from a whole CF mouse or disrupting CF just in the intestinal epithelia produces a lot of different gene expression difference between wild type and CF. So in summary, we have shown that both diets, the what we call protective diet and the diet that needed coli, both have the same histological changes, an increase in crib height along the whole small intestine, as well as increase in this muscle thickness of both the circular and longitudinal layer. But they are different in respect to the mucin content. The diet with coli have no difference in the amount of mucin content between wild type and CF, but the protective diet has more mucin, especially the acidic mucin in the CF mouse compared with the wild type. And when we look at the gene expression, there are thousands of genes differentially expressed between the two. And right now in here you can see some of the genes that are upregulated, some of the pathways that are upregulated in red, and some of the pathways that are downregulated shown in green. In the future, we are right now, just now, beginning to mine all of those differential pathways, trying to see if they can explain the difference that we see in the histology and the mucin content in the protective diet. We're going to repeat these experiments using the 7904 diet with coli and see if they can explain why these two diets have the same histological changes but difference in mucin. And finally, we want to do the same thing in the intestine of a CF humanized mouse to see how we can move it down into the patient side. And finally, I would like to thank the CF Foundation for supporting this research, and John Jaffrey for making the slides, the histology slides, and our CF mouse course headed by Craig Hodges, that without the mice that he created, we couldn't have done anything. And I'll take any questions.
This is Jens Leipziger from Denmark. It's not a question. I was involved in a study some 15 years ago where I helped another group from Hanover. Oliver Bachmann was the first author to isolate crypts from the colon, and then we did ion transport studies in these. And I definitively recall that the crypts of the CFTR knockout mouse were distinctly longer. And I think that should entertain you or make you happy. By the way, very nice presentation.
Thank you.
Nadia Amin from Yale. Really nice talk. Congratulations. So I wonder is there any data on human CF intestine in terms of looking at the muscle layers compared to normal human intestine? Are you aware of any differences that's been reported?
I have tried to find it, but I haven't. in humans.
Yeah.
I do have some humans that we have collected, but from both normal or non-CF patients and CF patients, but I have been hesitant to do anything because of the conditions that they were collected, so I'm not sure, what I'm going to find. But I haven't, doing a literature search, I haven't found anything in relation to the skeleton, to the muscle layer, but I have found about mucins.
Okay. And just a second question. Can you postulate on what you could hypothesize as to what the role CFTR is playing in this pathogenesis, both in terms of the muscle layer and the differences that you're seeing?
Well, that is definitely a conundrum, because definitely the mouse that we created, by we I mean Craig, that knockout CFTR in the intestine, that's just in the epithelia, but that definitely have a change in the muscle. So I cannot explain that yet. So it have to be some signal, something that is making the axonal CFTR in the epithelia causing that. But that I cannot answer you.
Steve Friedman from Harvard. I'm going to follow up on that. That's very nice. I know we showed a long time ago PPAR gamma was abnormal and perhaps playing a role in proliferation. I think I saw that in your RNA-seq bit.
Yes, it is.
My question is also about the changes in circular and longitudinal muscle. So is CFTR definitely in there? And are you going to it'd probably be interesting as you're doing these studies to be looking at, what happens with CFTR in the enteric neurons, because, CFTR is theoretically there in high abundance. And I don't know if that's what's driving this muscular hypertrophy.
Well, right now we haven't even begun yet, but we acquire a MERScope in the lab or in our center, and we're trying to look at where those genes are located, so we can actually follow that and see where they are. But we just send the genes that we wanted to look at as exploratory first. And so maybe next year I can tell you.
Zach Sellers, Stanford. Probably didn't expect to get so many questions on the muscle rather than the mucins, but I'm going to add to them. So have you looked at how many cells there are in the muscle layers? Is this hyperplasia versus hypertrophy?
Yes, that was the first question that comes to mind. And I tried that, but the way that the stain was done, I couldn't really count the cells in the muscle. I tried everything. I have to do something else. But the way that I have the slides made, I couldn't do that. I really tried, but I wasn't happy, so I cannot tell you that. That I cannot, but I definitely wanted to look at that.
Yeah, and I'm happy to hear that you guys are already in the process, I think, of looking at where your gene signatures or transcriptome game is coming from as to whether it's in the epithelium and the nerves or the muscle. So that's great.
Really interested in that. We're looking, but it's going to be a little while.
Yes, great work. Thank you.
Mike Narkwitz, Colorado. Really nice work. I guess my question is, the diet that you used didn't have cholite in it, right? How do we know this is not an effect of actually not relieving completely the partial obstruction, and the circular muscle hypertrophy is related to the fact that there's still a partial obstruction, which we know is a compensatory response in that situation?
Yeah, but the only thing that I have to say is that the same increase in muscle is in both, with and without cholide. So, I mean, that is present in both of them. Right now, I am beginning to actually look at the diet that usually have cholide, doing rolls without cholide in that, but I just prepare the rolls. I haven't done anything else. But yes, I mean, both of them have exactly the same thing, so.
Nice presentation, Lane Clark, University of Missouri. Just had a question about the regarding the increased crypt length and villus length and crypt depth. That we'd previously shown that there's an increase in the proximal part of the intestine, an increase in proliferation and stem cell proliferation in the crypts there. I was wondering if you looked
In
at
the proximal part?
in the proximal.
Oh, I'm sorry, somehow I missed that.
What?
No, somehow I missed that.
Oh, okay. Yeah, I was just in the proximal part. I was wondering if you looked at when beta-catenin signaling and stem cell proliferation or any of those markers all the way down the intestine.
That was something else that I tried. I used, I was the normal thing that people use, Ki-67 and PNCA, and I was not happy at all with the stain. So we tried a lot, and I ran out of time before the conference, so I can, because that's the first thing that you want to check, what it is, but I couldn't. And the other way to do it is to actually do it with live mice and injection following, but this is already after the fact, so I haven't done that.
Yeah, there's also EDU staining, so.
Yes.
Yeah. Okay, thank you.
Yunjie from Indiana, so very nice talk. My question is about the mucin. So you're looking at the AB staining and PAS staining. Are they from same goblet cells, and what's the physiological significance of this difference?
What is the physiological significance?
One type of the mucin is secrete more. Does it mean anything else?
Yes. Yeah. I also spend a lot of time reading because what mucins are the same. What distinguishes them is the amount of sialic acid in them. That the acidic one have more per mass than the neutral ones. And there's some people talk a lot about how that affects the bacterial population, and we're also working with looking at the bacteriome of our CF mice, but I haven't been able to connect the two yet. But that's one. And there's also a lot of work done in cancer and the type and how that affects the type of mucin.
Thank you.
Thank you. Thank you for that, Dr. Perez. That was great. Our next speaker is Dr. Mimi Saavedra. She's an associate professor of medicine at National Jewish Health in Denver, Colorado.
Or do I just talk?
Do you have slides?
Let's see here. You press start. Oh. They're supposed to be there. Should I go back to them and see? Well, they were there this morning. I'm sorry, folks. My slides seem to not be here.
My file.
Okay. Okay.
You could switch orders. That works.
Yeah, no, 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 okay. All right.
All right, I'm going to switch our order just slightly. So Ms. Farah Khan will be our next speaker. She is a clinical research project manager at Hospital for Sick Children in Toronto, Canada. Thank you for the flexibility.
Good morning, everyone. Thanks to the NACFC committee and the chairs for giving me this opportunity to share our research work here today. The topic of our study is to interrogate association of intestinal inflammation and abdominal pain, as well as intestinal polyps in people with CF. I and other authors have no disclosures regarding this study. Cystic fibrosis is a progressive multi-organ disease that involves airways, sweat glands, biliary system, and GI tract. The GI tract diseases cause a significant burden on people with CF, and one of the most common symptoms is abdominal pain. One study of 131 CF participants showed that 87% of children and 70% adults reported abdominal pain. Another one, the Galaxy study of 402 CF participants showed that about 4% of children and 7% adults reported moderate to very severe lower abdominal pain. There is a concept of CF gut, according to which defective CFTR in intestine causes luminal dehydration and accumulation of viscous mucus, leading to the changes in intestinal milieu. This promotes dysbiosis, inflammation, and dysmotility, which further alters the intestinal milieu, which then enters into a vicious cycle. We believe that this CF gut explains a larger number of GI symptoms, such as abdominal pain, constipation, etc. There is numerous evidence of presence of intestinal inflammation in CF. Here, just highlighting some studies. A video capsule endoscopy study in people with CF found signs of intestinal inflammation in 63%. A study evaluating rectal tissue biopsies in 11 children found mild inflammation in 4. Another study showed increase in fecal calprotectin and abdominal score in those with abdominal pain. Since we live in an era of Trikafta, we also cannot ignore that Trikafta may have an effect on abdominal pain and intestinal inflammation, as shown in Recover and Promise study here. This leads us to the aims of our study, that are to determine whether abdominal pain is associated with intestinal inflammation in people with CF, and to determine if intestinal inflammation is associated with intestinal polypus lesions in people with CF. We designed this study to run at 2 centers, pediatric participants recruited at the Hospital of Sick Children in Toronto, and adult participants recruited at St. Michael's Hospital, Toronto. We included participants of age 10 years or older. For adult participants, we included only the ones who are undergoing colonoscopy as part of routine screening. Since IBD, acute exacerbation, and infection has a role in intestinal inflammation, these participants were excluded from this study. We asked participants to complete questionnaire of abdominal symptoms, which included history of GI conditions, bowel habit, presence of abdominal pain, if yes, the characteristics. We asked participants to provide a stool sample for fecal cal analysis. In addition, the adult participants who were undergoing routine colonoscopy, we collected biopsies from 4 areas: terminal ileum, right, mid, and left colon. We also noted presence of any lesions during colonoscopy. Since the diagnosis of GI disease can confound abdominal pain, we decided to form 4 different groups: no abdominal pain with or without GI condition, abdominal pain with or without GI condition. We did proportion analysis using Fisher-Exact test and multivariable logistic regression to analyze predictor for polypus lesions. The table at the bottom provides a nice overview of a study recruitment. We recruited 46 children. Among those, 44 provided stool sample for fecal cat analysis. In adult, 47% were recruited. But since adults were more comfortable providing biopsies than stool samples, we have 42 samples for histology and only 22 for fecal cat analysis. Our first objective was to look if there is an association between abdominal pain and intestinal inflammation. We'll start with the pediatric cohort. Out of 46 children, 63% reported abdominal pain. As we mentioned before, to limit confounding by a GI condition, we divided the pain, no pain group further into GI condition and no GI condition groups. As you can see, the constipation was the most common GI condition in pain and no pain group. Looking at more details, 89% were pancreas insufficient and around 43% were on CFTR modulator treatment. We observed a positive association between abdominal pain and elevated fecal calprotectin in children. The table shows that median fecal calprotectin level were statistically significantly higher in the pain group compared to the no pain group. Further, as shown in the proportion graph, significantly more children with pain had borderline or elevated fecal calprotectin. There are more details in the right graph. Each dot represents a single patient. A line represents the median and interquartile ranges. Patients that are color-coded blue are on CFTR modulator treatment, yellow on systemic treatment, which is the oral antibiotic or immunosuppressive treatment, and the green ones are on the both type of treatment. Again, the graph shows higher fecal cal levels in the pain group compared to the no pain group. It also shows that most children that are in no pain group are on CFTR modulator treatment. What is interesting to see here is some of these children have higher fecal cal levels, which is a sign of intestinal inflammation. About 45% children in our cohort were on CFTR modulator treatment. So we examined how this affects abdominal pain and intestinal inflammation. There were more children on CFTR modulator in no pain group, and we observed a tendency of more normal fecal calprotectin in those on CFTR modulator. However, as the table shows, when we look at the children on only those on treatment, whether we see it in all children or only those who are off treatment, the mean fecal calprotectin level is significantly higher in children with abdominal pain. Coming to the adult cohort, out of 47 participants, 38% reported abdominal pain, which is less than what we saw in pediatric cohort. We can see here that the main reported GI condition was constipation and DIOS in both groups. Looking at more details here, 83% of all adults were pancreas insufficient and 53% were on CFTR modulator treatment. In adults, we saw the highest fecal cal level in those with no pain and lower levels in those with pain. Here you can see this. It's likely because most of all adults with pain also had a GI condition, which was most commonly constipation and DIOS. What is interesting to note here is some adults who reported abdominal pain were on CFTR modulator treatment. Okay, sorry, my mouse keep going here. So they're on CFTR modulator treatment, similar to what we saw in children. In proportion graph, there was no difference in the number of adults with abnormal fecal cal levels between pain and no pain groups. Next, we looked at the intestinal mucosal inflammation in adults. 42 out of 42 adults, 62% had evidence of intestinal mucosal inflammation in terminal ileum or colon or both. About 60% of adults in our group had inflammation only in the colon, which was mostly found in transverse colon, and about another 30% was in association with inflammation in terminal ileum. The inflammation was graded into 4 groups as no inflammation, mild, moderate, mild, moderate to severe, and severe. It's based on the abundance of inflammatory cells, and typed as acute and chronic based on types of cells. We can see here that the most biopsies had inflammation of mild and chronic type and was mostly found in colon. We also looked at the crypt changes and fibrosis. 5 adults with mild chronic inflammation showed changes in the crypts. Mainly they were dilated crypts with mucus. No one had fibrosis. Next, we look at the association of abdominal pain with inflammation on histology. There was no difference in inflammation on histology between those with and without abdominal pain. Something to note here that the patient with moderate to severe inflammation are in no pain group. Around 50% of our adults were on CFTR modulator treatment. We can see here that there is no effect of CFTR modulator treatment on abdominal pain, fecal capitectin, or histology on adults. Our next study aim was to evaluate whether there is a relationship of intestinal inflammation with polypus lesions. It is reported that people with CF had 10 times higher risk of large bowel cancer compared to the general population. In addition, the intestinal polyps have a potential of becoming precancerous lesion, and their removal mitigates the risk of CRC. The proposed etiologies of CRC in people with CF are intestinal inflammation, dysbiosis, increased cell turnover, and loss or reduced CFTR gene function as tumor suppressor gene. Now let's look at the polyps data. Among 47 adults, 38% had polyps identified in colonoscopies. Those were most commonly found in descending colon, and all of those were adenomas. 4 patients had more than 3 polyps. We compared the presence of inflammation on histology or via calprotectin between adults with or without intestinal polyps. We can see that there was no statistically significant difference. Further, in the proportion graph, we can see that there was no difference in the number of adults with polyps between those with and without intestinal inflammation on histology. We have done a logistic regression modeling to look at the variable predicting the risk of polyps. Here, the solid lines are for mild mutation with or without GI condition, and the dotted line are for severe mutation with or without GI condition. We found that sex, CFTR modulator treatment, abdominal pain, and inflammation on histology had no significant effect in our cohort. And notice that age had an effect with increasing risk of increasing risk for polyps with increasing age. Very interestingly, and to our surprise, adult carrying mild CFTR genotype had a higher risk for polyps. CFTR genotypes are listed in the table below. Further, presence of GI condition had a lower polyp risk. One condition could be PEG treatment, since most of the GI condition was constipation and DIOS. This may have a protective effect. In conclusion, in CF children but not adults, we found an association between abdominal pain and intestinal inflammation measured as fecal capitectin. Mucosal inflammation in CF adult was predominantly chronic and mild type, mainly involving the transverse colon. We found no association between intestinal mucosal inflammation and intestinal polyps in our cohort. In our adult cohort, mild CF genotypes but not intestinal inflammation were associated with risk of intestinal polyps. At the end, I would like to acknowledge that this study was only doable due to the great collaboration between CF teams at SickKids, CF Center at SickKids, St. Michael's Hospital, adult GI team, and adult pathology. And a specific thanks also goes to Liron, who helped design this study. Thank you.
Steve Friedman from Harvard. Thank you. That was great. 2 quick questions. One is, on this mild inflammation, was this scored with basically blinded pathologists doing this? Because I'm not sure, we've all been looking at this, you don't really see inflammation in that you can correlate with anything.
Yeah, I wouldn't say the pathologist was blinded, but the adult pathologist looked at the slides. Yeah.
And in the kids who had elevated fecal calprotectin, it's actually borderline. And actually, the real fecal calprotectin that's elevated went down. So, do you want to just comment on that? Because I'm not sure that correlates with anything. And obviously, the adults tells you that probably that hypothesis is wrong. And all this constipation in the background probably is suggesting more that maybe the pain is related to a dysmotility rather than a true inflammatory condition here.
Yes. For this, I'll go back to my slide here. And here. So for this reason, just to avoid the confounding, so we grouped the pain group with GI condition and without GI condition. So we can see here that there are a lot more kids without GI condition and they have inflammation as compared to the ones with GI condition. So you are right, there are like at the borderline, but these are the ranges we generally see in other studies. Like this borderline measure is 118. So generally the fecal calprotectin levels we see is around like the same levels, what studies we have so far. And sorry, I forgot your other parts of the question.
That's okay. I think the last thing, I just want everyone to be very cautious that on your mild genotype associated with polyps, I don't want people to get the wrong opinion that if you have a severe genotype, we shouldn't be screening you with colonoscopy so aggressively. You have very unequal numbers of enrollment, and we probably have one of the largest centers for colonoscopy, and we haven't seen a correlation with genotype. So you have very unequal enrollment numbers, which could explain that.
So in adults, it's like the 47 adults who had this colonoscopy and we find polyps. And you're right, I haven't come across a study that shows a mild genotype being associated with presence of polyps. Honestly, there is no study done, I think. So this is something definitely to look further. And
I think Christine Hatcham is sitting over there leading the NICE-CF study. I think we're going to be getting a lot of info over the next year or two, perhaps how this relates genotype and polyps and whether there's a role of non-invasive colorectal screening.
It will be interesting to see.
Thank you very much for a nice presentation. Mark Chilvers from Vancouver. As with all great research, it leads to more questions than answers. So I think we can see that from your data, which is great. You looked at the impact of CFTR modulators in the pediatric population. Was there a signal? Did you look at that in the adult population at all?
Yes, we did. And so I'll take you the slide here. We did not see a significant difference there. Here. Sorry, that's abdominal pain. So here, so the difference wasn't significant. So it also depends on like which CFTR modulator they were on and the duration of CFTR modulator treatment. So it's like a cross-sectional study, like a snapshot of the population. So it will be interesting to see like over the time how they perform.
Great. Thank you very much.
Thank you.
Hello, Zeph Minkoff from Valley Children's. Could you go back to the slide that you just had up before of the, so I'm looking at this, and please let me know if you, sorry, the pediatric, not the adults. Perfect. So what I'm seeing here is that there's pain, and then there's pain plus GI condition. Pain plus GI condition essentially means constipation for the majority of these patients, right? In my impression, we're saying that if you have pain and constipation, then likely maybe that pain is related to the constipation, versus pain without constipation, that's more likely to represent inflammation as the cause of the pain. Do you think that would be a fair assessment?
That's what we are saying here.
Okay.
Exactly. Yeah, this is without constipation or DIOS, and this one is with constipation.
Okay. Would you therefore caution making a diagnosis of irritable bowel syndrome in patients with cystic fibrosis? Because that would be one, like, I guess, not the constipation predominant part, but we, having patients with pain, and if they don't have constipation, often we would maybe call this IBS if everything else is normal, but maybe that's underestimating the inflammation that these patients are having.
Yeah, so to control that confounding, we excluded this participants from our study, patients with IBD.
Oh, I said irritable bowel syndrome, not
Irritable
inflammatory.
bowel syndrome.
Yeah, sorry.
No, yeah.
Okay.
Thank you.
There's a question from the app. Do we know the cause of pancreatitis that was seen in CF adult cohort as a reason for abdominal pain?
So pancreatitis and CF, it's most likely be because of CF, right? So we did not specifically look at the reason behind those pancreatitis episodes. Is because we need to go in there and dig deep. But in adults, we can see that there are just 2 patients, and they are in no pain group. So it means when we collected the sample, these patients were not having that pancreatitis episode. All right, thank you.
Okay. Next, we will hear from Miss Ava Cho from BC Children's Hospital in Vancouver, Canada. Wait, never mind. We'll go back. Sorry.
Jump back to that.
Yes, that would be great. We are switching again. So Dr. Mimi Cervera, Associate Professor of Medicine at National Jewish Health in Denver, Colorado. Thank you.
Then you use the clicker.
Use this. Don't use.
Clicker. It says forward. Forward. Backwards.
Okay. I am so sorry about that. This has never happened to me before, but I promise you the slides were there. So thank you for your patience with me. I want to thank Nicole and Michael for inviting me to speak at this session. And I'm going to talk to you about plasma metabolomics pre and post CFTR rescue ETI Trikafta. I have no disclosures. And this is kind of funny that this whole thing happened to me because, to be honest, I was struggling to find my place in a GI session. So I'm a pulmonologist. I work on immunity in the lung, and I work on topics such as what you see here in these beautiful pictures from Max Krummel. And what you see there is antigen presentation. And so you can see a green T cell palpating a very much larger dendritic cell, and that's the process of antigen presentation taking place. And so you can see what a dynamic relationship that is, and that the T cell and the dendritic cell are interdigitating all these different places where they're making contact. None of that would be possible without specific metabolic processes happening within the cells. And so going back to the session then, I said to myself, because I also do clinical care, and I said, well, what are the ongoing questions after starting ETI that continue to come up for us from a clinical standpoint? And that is, why do the GI sequelae of ETI seem to underperform the pulmonary improvements that we see in some patients? Why do some patients fail to gain weight and yet others gain so much weight? And why do some patients continue to experience pretty crippling episodes of DOS? We don't really have a good way of separating those subpopulations or really even understanding what's happening. And in the context of that, I thought I would put up a recent report from Promise GI. It's from earlier this year from Schwarzenberg's group, from the Promise investigators. And what they reported in summary was that at 6 months, statistically significant but clinically unimportant changes were seen in CF inflammation. And so that brings up this issue of metabolism again and how it relates to what's happening when we give people these drugs. So suffice it to say, the relationship between metabolism, immunity, and CFTR rescue is incompletely understood. So our hypothesis was that we would use plasma, yes, plasma metabolomic profiles, so not from the tissue, but from the plasma, which is easy to access, to see if we could identify primary metabolite classes or families that were underlying reductions of inflammation after starting ETI. And I guess our overarching goal in doing this research is to say, can we use this platform? Can metabolomics as a platform help us understand a link between nutrition and systemic and intestinal inflammation when you are looking at samples from humans to help kind of fill in some of the beautiful animal data that's being presented here today? So plasma, why plasma? Plasma is the transport river of our bodies, right? So basically it absorbs it includes absorbed nutrients from the gut that it takes to tissues that need it, such as glucose, fats, amino acids, minerals, salts, enzymes, vitamins. But it also transports waste away once cellular metabolism has occurred, mostly to the kidneys and the liver. And so it's this kind of rich substrate for trying to ask some of these questions. So the methods for our study was that we took a cohort of patients, so 20 patients pre and post Trikafta. On average, it was immediately before starting Trikafta and then 5 to 6 months after being on Trikafta. And the waterfall plot, you can see that there is a range of percent predicted FEV1s in the patients pre-Trikafta. And then what we did with those patients is we recorded clinical data. We looked at their T cells. So we looked at what was happening on a cellular basis from a transcriptomic standpoint and from a surface protein marker standpoint. But we also looked at the metabolomics in the plasma. And that's what I'm going to talk about today. It was a global panel of 142 metabolites, and it covered 21 classes, and key classes were included: amino acids, nucleotides, multiple types of fatty acids, including the fatty acids that are found in the plasma membrane. And then based on that, we analyzed it multiple different ways. Initially, obviously, most basically, we looked at changes in the metabolome before and after treatment with ETI. But we also wanted to see, how do metabolites change in association with FEV1 and hospitalizations? And how do metabolites change in association with weight? So this is our study cohort. The cohort is small, and some of the data that I will show you has borderline p-values or perhaps raw p-values that are significant and adjusted that are not. But it's really just trying to set a framework for how this data may be useful. The cohort reflected most Trikafta cohorts. There was significant reductions in exacerbations in the year after treatment. There were significant improvements in FEV1, and there was a significant increase in weight, on average 3.7 kilos. So this figure is basically showing the same thing in two different ways, right? So it's looking at individual metabolites modified by ETI. On the right is a heat map, and what you can see is to the far right, so under the green column, are the 20 metabolites most highly differentially expressed after ETI. The red are upregulated, the blue are downregulated, And in the upregulated, you do see a fair amount of representation of polyunsaturated fatty acids as well as acylcarnitines. On the left is a volcano plot, and what you can see there is a little bit of a sense of the degree of fold change between the different metabolites. We were also interested, because remember I mentioned in the methods that we were looking at classes, and so we wanted to try to see, are there relationships that are happening with classes themselves, so we could say which are primary pathways that may be affected by ETI. And so we went class by class. TCA cycles seemed about flat, so some metabolites went up and some went down. In the nucleotide category, actually all 4 of the ones that significantly or nearly significantly trended down are in the purine degradation pathway. Amino acids also tended to go down after ETI, and all of the amino acids which trended downward or significantly went downward are glucogenic amino acids. When it came to the lipids, the acylcarnitine fatty acids had a lot of representation in terms of significant changes. And so while the first one looks like it went down, all of the other ones tended to go up, some more significantly than others. And that takes us to the pathway that they're involved with. So the carnitine shuttle basically helps transport long-chain fatty acids into the mitochondria where they can undergo beta oxidation and produce ATP for energy. And so these acylcarnitine transporters appear to be, as a group, increased after the treatment is initiated with ETI. Sphingolipids, and in particular the 2 that are represented here, sphingosine and its backbone ethanolamine, these 2 are pro-inflammatory ceramide components, and so they tend to go down. Another set of lipids, so sphingolipids are a part of the plasma membrane, polyunsaturated fatty acids are a part of the plasma membrane. We all know that there are major changes in the plasma membrane in CF cells. And so what you can see here is that polyunsaturated fatty acids as a group, so that's omega-3 and omega-6 fatty acids, tend to go up. The next thing that we looked at is seeing that there were changes that seemed to happen within classes. Were those changes correlated with each other? And so if you look to the far left, in some situations, they really weren't. So nucleotides, not so much correlation. Amino acids, maybe a little bit of more correlation within certain groups. But when you came to the carnitine fatty acids, there seemed to be a hotspot of a group of them that really are correlated with each other and seem to move in the same fashion, bringing up the question, is this something related to improved absorption, improved uptake? Then when you go further, though, into the fatty acids, they really tend to get hotter and hotter. And so the correlations between monounsaturated fatty acids, polyunsaturated fatty acids, and saturated fatty acids within each other as a class seem to actually be pretty high and higher than the other metabolic classes. When we did a network analysis to see, are these classes that I'm talking about within the lipids related to each other, what we found was that yes, there are. And so long chain fatty acids, which tend to go through beta oxidation, and then the omega-3 and omega-6 polyunsaturated fatty acids and sphingolipids, so looking at the plasma membrane, they all tend to be associated with each other. So then the question comes up to clinical outcomes, right? So this is all interesting, but then how does it relate back to patients and understanding what is happening to patients' metabolism when they take these drugs based on associations, which actually are probably the first step to lead you down the basic science experiments that we need to do to try to figure these things out. And so when we looked at metabolites, So how do the metabolites predict weight? And how do the metabolites predict inflammation, which in this study was represented as change in hospitalizations after the start of Trikafta? And to give you an example, what you see on the top is that the top 4 metabolites tend to go up as weight goes up. And so to kind of put a number on it or quantify it a little bit better is that last column that says delta weight. It's delta kilos. So per 25% increase in dodecanoic acid, for example, we see a 1.11 kilogram increase. And so if you look at the p-values and the FDR, you can see that you lose significance when you do multiple corrections, but it's a small group, and this is something that probably should be studied in bigger detail, which we hope to do when we are doing this in a larger cohort. When you look at the relationship with inflammation, metabolites seem to have a stronger relationship with inflammation. And so as an example, similar to what I just did with the other table, is that if you look at the first one, 2-oxoglutarate, so for a 10% increase in that metabolite, that is associated with a 50% increase in hospitalization rates. And that relationship, when you look at the FDRs and the p-values, is stronger with metabolites than weight. And so you can see that it goes in 2 different directions, but you can use both to kind of look at patient outcomes and what's more related to absorption and what's more related to inflammation in general. So the thing that was reassuring to us is there's a nice big, well, relatively big literature looking at the metabolome. There's a lot known about known metabolic differences in CF. We know that there's abnormal bile acid processing, decreased beta oxidation of fatty acids, lipid metabolism is altered. This has been looked at in animal models, in plasma, in BAL fluid, in airway cells. And we know that the latter 2 tend to improve after you reduce inflammation, for example, after you treat a pulmonary exacerbation. And so those things are associated with better energy expenditure, better energy production, and reduced inflammation, starting to bring this concept of inflammation and metabolism together. When we looked, instead of at individual metabolites, at metabolite classes, what the 2 most significant metabolite classes were that were associated with increase in weight were the bile acid family and also the beta oxidation of fatty acid group, or the acylcarnitines. What about subtypes of inflammation? And so we looked at this concept of, does the metabolome track with neutrophilic inflammation, lymphocytic inflammation, monocytic inflammation? And if you look at those p-values in FDR, the only one I'll focus on is the neutrophilic inflammation. And so when you use the neutrophils as the predictor and the metabolites as the outcome, then it appears there is a relationship or a suggestion of a relationship between bilirubin and a tryptophan metabolite. And so for every 1% increase in your neutrophil percentage in the blood, you get a 5% reduction in your circulating bilirubin. And so there appears to be that there may be subsets of inflammation that you can track using the metabolomic platform. The reason why I go into this in so many different variations in so many different ways is that there appears to be some depth and some richness to using metabolomics with clinical outcomes, knowing what we know physiologically about what happens after ETI rescue. This particular figure is negative data, actually. And so this is when we take these very same plasma samples and put them on a cytokine array and just measure a panel of cytokines. None of them significantly changed, despite the fact that so many different things were happening within the metabolome. I'm going to walk you through, I'm almost at the end, but I'm just going to walk you through these two heat maps to try to get a little bit of a sense of how you could use this to understand the heterogeneity within populations, the patients who gain weight, the patients who don't, the patients who keep having symptoms, and the patients who don't, using this as a potential biomarker approach. So to the, what's it on your right? That's on your right. My right is a heat map. And on the rows are the metabolites. At the very top of that heat map is clinical data, and those are the green boxes. And that clinical data is delta weight. And so the scale is from 0 to 10 kilos. And so you can see that where those tallest green boxes are evident, there's really two categories of patients. There's the ones that are closest to me from this side, and those seem to really have an increase in the acyl carnitine group, suggesting that there may be differences in the way they create energy. But then there's also this second group that also gained a significant amount of weight that doesn't appear to have that happening. And so this is just kind of one example of how you could begin to stratify patients based on their metabolomic signature. On the other side is a similar representation. You don't see that same pattern happening, but what the clinical outcome is hospitalizations at the top of that. And so this DNH means delta in the number of hospitalizations, and the scale on this one is from 0 to -6. So those patients had either no change in hospitalizations or dropped to like 6 less per year after starting Trikafta or ETI. And you can see there that there is that group that really had the greatest drops. Using this platform also appears to have this biphasic pattern. And so it's a nice example of how you can use modeling and patient samples, which are readily available, which are available through PROMISE, which are available through many clinical studies, to try to stratify these patients after treatment with this very important drug. So in conclusion, it appears that maybe there can be some links found between inflammation and metabolism using this approach. Number one, we saw that there were significant changes before and after ETI using the metabolome. We could also see a reversal of well-described CF metabolic derangements, which happen at the tissue level, the plasma level. Metabolites associate with weight. Now, it's hard to say, what the link is. Is it absorption? Is it there's less nutritional loss? Is it that there's less, better energy use or less dysbiosis? That's a whole other field to go into. They associate even better with inflammation, bringing the weight and the inflammation together. And I think this is a kind of studies that I think we could do elegantly with more developed data sets. So when we actually have GI endpoints, GI inflammation, microbiome, sweat chloride, so that we can kind of start to see what seems to be a primary effect of the drug versus secondary related to downstream changes in GI and lung inflammation. Now, I didn't talk to you about the other side of the study that we did, which was related to transcriptomics and what's happening to immune cells after you treat with Trikafta. But what we think is that CFTR rescue, as reflected in the metabolome that's circulating and easy to reach, may be doing a very similar thing to what we see at the cellular level, and that is that there is an improvement in energy generation in general. There is more oxidative phosphorylation in the tissues, and that leads to multiple outcomes, but it doesn't happen in every patient. And so this may be an important thing to track in the future. Finally, I'd like to thank the folks at our center. Brian Vestal is our biostatistical genius extraordinaire who helped set up all these models so that we can start to ask these questions. Noelle, Katie, and Sylvia literally make everything run with collecting these samples and making sure that they're well characterized. The metabolomics core was a tremendous partner in getting all this stuff analyzed, and many thanks to Scott Sagal, also at Children's, who is a part of this project as well. So thank you to my team. Thank you to the patients.
That was fantastic. Does anyone have any questions?
If I take the kidney hat on my head, I have to think about volume homeostasis, and correction. An ETI treatment actually has a significant effect on volume homeostasis and corrects the salt wasting phenotype. Where there's a poster 357 where you can see this, and the weight gain is quite significant. So if you discuss the weight gain, you have to accommodate also the change of how much volume you have in your body, which is a significant confounder, I think, in these reflections.
I agree. That's a really wonderful point. And I've been thinking, like, how is there a way that we could do it where we take into account the osmolytes and somehow use that as a surrogate? But that's a fantastic point. Yeah, that's really well described. Thank you for that.
Hi, good talk. Really interesting, the immunity metabolism that you show. Are you taking into account the neutrophil, the numbers of neutrophils because of infection? Like, if you have more infection, you have more neutrophils?
Yeah, so this was kind of a small study, but you're right. With the larger group, we're going to try to adjust for those things so that we can make sure that it's not a confounder.
Thanks.
Yeah.
There's a question on the app. First of all, very cool talk. You mentioned possibly using these metabolites as biomarkers for patients to predict increased hospitalizations. Did your team test whether the cohorts association, for example, of citrate being associated with high hospitalizations on other populations?
We are doing we are doing this in a larger study, and we will have like 7 times more patients, and in that we'll test those.
Great. And were patients fasted overnight before sample collection? And can you also comment on the patient's nutritional status? And finally, with that question, what could elevated succinate mean?
What could
the elevated succinate mean?
Oh, okay. So, nope, this was completely an imperfect study. They didn't get them fasting. I didn't have any food diaries. This was just kind of like Trikafta was approved, and let's just see what we can. So the secondary study actually is much more stringent, and we'll have that. And so I think that will be, that will be easier in terms of like being able to draw more reliable conclusions. The succinate, so succinate is an important intermediate in the TCA cycle. It has, and I struggle a little bit with that. I'm not completely sure because there have been associations with increased inflammation. But, the TCI cycle is also important for feeding into some of the more effective metabolic and energy expenditure processes that I was just talking about. So I don't know the answer to that yet.
Okay. And then one more question, and you touched on some of this question, but the interaction between metabolomics and gene mutation and infection. So with the gene mutations, sort of milder and more severe gene mutations within CF, and then sort of infections and microbiome and dietary factors. So all other things to be looking at.
Oh, in terms of adjusting for phenotype.
Genotype.
Yeah. We do try to do that in our studies when we have bigger groups, but yes.
Okay. All right.
Thank you.
Yeah. Okay, and next we have Miss Ava Cho, who's at BC Children's Hospital in Vancouver, Canada. I think we should back on that. Sorry about the confusion. It's okay.
Okay, do you see yours there?
Yep.
Thank you to the moderators for inviting me to speak today. I have no disclosures. So with the approval of ETI in Canada for ages 12 and above in June of 2021, in preparation for drug initiation, we included baseline and follow-up investigations to monitor for efficacy and safety. Recovery of pancreatic function has been reported in the literature in some young patients on modulator therapy. And at our clinic, majority of our patients gained access to earlier modulators through trial participation. And as a result, we did not have routine clinical monitoring of elastase unless there was indication to do so. Therefore, prior to transitioning to ETI, if already receiving any prior modulator, a baseline fecal elastase was requested. And in a few patients on Lumaiva, we unexpectedly observed pancreatic recovery, which led us to this quality improvement initiative to review all of our clinic patients who converted to pancreatic sufficiency while receiving any modulator therapy. Our objectives were to describe these patients, to report on growth and nutritional outcomes, as well as to use this data to guide future practice. So we reviewed all of our clinic patients for anyone who received modulator therapy as well as had a fecal elastase result. And pancreatic sufficiency was defined as anyone that had a fecal elastase that had greater than 200. And in those patients that we identified to have recovered pancreatic function, we further collected demographic information, growth, enzyme and ADAC vitamin usage, as well as vitamin levels. Between April 2010 and August of 2023, we identified a total of 105 patients who were treated with modulator therapy. And you can see the breakdown by row, each modulator that the patients were on. In total, there were 95 patients that were pancreatic insufficient before modulator therapy. And 95 of the 95 patients, 60 patients provided fecal elastase samples. In total, we received 82 samples from these 60 patients because some patients gave us multiple samples. In total, there were 10 patients that were found to be pancreatic sufficient, noted to have a fecal elastase above 200. I will now present the baseline characteristics of the 10 patients that converted to pancreatic sufficiency. 9 of the patients were male. 5 were homozygous for F5 weight del, and of note, 1 of the patients had a stop mutation. In terms of age of diagnosis, 1 patient was diagnosed antenatally, 4 patients via newborn screening, and for those diagnosed prior to newborn screening, they were diagnosed between 1.5 months to 4 years, 10 months of age. 3 patients were on ivacaftor, 5 on Lumaiva, and 2 on ETI when they were discovered to have pancreatic sufficiency. The median age that these patients were started on modulator therapy was 6.6 years. The highest age was 14.3 years. The median age that pancreatic recovery was identified was 14.8 years, ranging up to 18.3 years. The median time that these patients were on modular therapy when the pancreatic recovery was identified was 4.9 years. And of the 10 patients that recovered pancreatic function, 9 patients stopped PERT. This graph shows the change in fecal elastase. This graph shows the change in fecal elastase over time in years for all 10 patients, as well as the different modulators that they were receiving at the time when pancreatic sufficiency was identified. Values above 200, as indicated by this dotted line, is what indicates pancreatic insufficiency. I will further now discuss each individual case by modulator. So these 3 patients converted to pancreatic sufficiency while on ivacaftor. Patient number 1 in blue here started on ivacaftor at 6 years, 7 months old as a trial participant, and after 8.5 years, at about 15 years old, she told us that she stopped taking her enzymes and had no symptoms. A fecal elastase of 213 confirmed that she was pancreatic sufficient, so we officially discontinued her PERT. However, after 13 months, she presented to hospital in acute pancreatitis and subsequently had 2 more episodes of acute pancreatitis over 3 years. She also started to notice some symptoms of stomach discomfort when she was having high-fat meals, and so we recommended restarting a low dose of PERT. Despite her symptoms, her fecal elastase continued to increase, and by the time she graduated to the adult clinic, she was no longer taking PERT consistently. Patient number 2 here in darker blue started on ivacaftor at just 12 years old. After 5.5 years, at 17 years old, he also told us that he stopped taking his enzymes. And a fecal elastase of 263 confirmed that he was pancreatic sufficient. He continued to be off PERT by the time he graduated. Patient number 3 here in light blue started on ivacaftor at 11 years old. And after 3.5 years of being on ivacaftor, we noticed that his enzyme pickup refill was poor from the pharmacy. And so we requested for a fecal elastase, and that came back just over 200 at 203. Growth for this child was not optimal. It was less than the 5th percentile, and we wanted to confirm pancreatitis with another elastase sample. However, we never did receive the sample before he graduated, and this is our one and only patient where PERT was not stopped despite an elastase above 200. These 2 patients were on Lumaiva when they converted to pancreatic sufficiency. Patient number 4 here in yellow started on Lumaiva at 23 months old as a trial participant. After 7 months on Lumaiva, the elastase increased to 146, and after 23 months, it increased up to 311, which shows pancreatic sufficiency. PERT was discontinued, and an elastase taken 7 months after continued to show pancreatic sufficiency at 374. Patient number 5, I believe he's the oldest patient reported to date who recovered pancreatic function on Lumaiva. He started on Lumaiva at 12 years, 2.5 months of age, and discovered to have pancreatic recovery when we were transitioning him to EDI and we were preparing his files. He had just turned 18, and we were still waiting for the funding approval to come through when his elastase result came back at 307. It was at his graduation clinic that we recommended that he stop his PERT, and I do not have any follow-up data on him. The next 3 patients were all on Lumaiva when they converted to pancreatic sufficiency, and then they transitioned over to ETI. The first elastase for each of these patients, the top of the curves for each of these patients, were taken while on Lumaiva. All subsequent elastases were taken while the patients were on ETI. Patient number 6 started on Lumaiva at 3 years old as a trial participant, and after 4.5 years of being on Lumaiva, his elastase was 261 and PERT was discontinued. At 8.5 years old, as indicated by this purple arrow, he transitioned to ETI, and after 7 months on ETI, his elastase decreased to 212. This is still in the sufficient range, so this patient continues to remain off of PERT therapy. Patient number 7 here in light green was on Lumaiva, started at 9.3 years old as a trial participant, and in preparation for ETI transition, an elastase was taken almost 7 years after taking Lumaiva, and it was increased to 226, and PERT was discontinued. He soon transitioned to ETI, and after 6 months on ETI, his elastase decreased down to 50. This patient's sample was dropped in the toilet, and the parents were unsure if this would affect the results. So they sent in another sample, which came back at 74, which still showed in the severe pancreatic insufficient range. This patient continues to demonstrate good growth, no symptoms of malabsorption, adequate vitamin levels, and the family's reluctant to restart PERT unless necessary, and he currently remains off of PERT, and we continue to monitor him closely. Patient number 8 here in moss green started on LUM-IVA at 2.5 years old as a trial participant. And in preparation for transition to ETI, an elastase was taken almost at 6 years old, 6 years on LUM-IVA, and it came back at 205, which is just over 200. And we wanted to confirm pancreatic status with another sample, but he soon transitioned to ETI about 1 month later. After 5 months after receiving ETI, we took another sample, and it had decreased down to 199. Despite this number, the parents were quite eager to try stopping PERT because occasional intentional enzyme misses resulted in no GI symptoms. He's currently off PERT, and we are currently still waiting for a pending result of an elastase sample submitted recently. My last 2 patients were on ETI when pancreatic recovery was identified. Patient number 9 here in pink started on ETI at 4 years old as a trial participant. After 7 months, his elastase increased to 255 and PERT was discontinued. And you can see his elastase continues to trend up. After 22 months on ETI, his most recent result is 492. Patient number 10 here in purple, I believe, is the oldest patient reported to date who recovered pancreatic function on ETI. He started ETI at 14 years, 3 months of age, and after 6 months, his elastase increased to 241 and PERT was discontinued. Subsequent monitoring showed fluctuations within the mild to moderate insufficient range. The elastase declined to 124 at 1 year, down to 105 at 1.7 years, and up to 142 at 1.9 years. This patient's BMI was above the 99th percentile. He had no symptoms of malabsorption, and his vitamin levels are adequate as well. They were also reluctant to restart PERT, and therefore he remains off of PERT, and we are continuing to monitor him closely. This chart shows the change in BMI percentile for all of my patients. In blue represents the patients before starting modulator therapy, in orange after modulator therapy but before pancreatic recovery, and in gray after pancreatic recovery. The space between these 2 dotted lines indicates what the WHO definition is for a healthy BMI, which is between the 5th and the 85th percentile. Highlighting to you number 3, patient number 3. He was our one patient who we did not stop PERT. And the reason why is because even after starting ivacaftor, his BMI continued to decline underneath the 5th percentile. All of our other patients did stop PERT, and you can see that their BMI percentile is either within or above the healthy range. This table shows the nutritional parameters that are changed for our patients for before our modulator was started in column 2, after modulator was started in column 3, and then after pancreatic recovery in column 4. Median doses of PERT were observed to decrease after starting modulator therapy, and after pancreatic recovery, only 1 patient remained on PERT, and this was his dose. At the same time as stopping PERT, 2 patients were also asked to discontinue their ADEX supplementation. And in terms of vitamin levels, for most of the patients, they remained stable, except for in 1 patient. This was patient number 9. He was noted to have elevated A and E levels after 2 months of stopping PERT. As soon as we had this result, we stopped his ADEX supplementation and we checked his vitamin levels in 6 months, but his vitamin A continued to increase. Now at almost 12 months off of PERT as well as ADAC, his most recent vitamin A level has finally fallen within normal range. In conducting this review, there are some interesting findings as well as some questions to think about that I would like to highlight. In our cohort, there was a higher recovery observed in males. I'm unsure if this is actually just unique to our cohort or not, because not all of the cases reported in the literature identified the sex of the individual. We also observed pancreatic recovery in patients that we did not expect because they actually started on modulator therapy at an age older than those previously reported in the literature. And is it too early to tell? I think the whole talk this morning has been this big question is what is the modulator's effect and ETI's effect going to be on the pancreas? Will we see more recovery as we start younger patients on ETI? And will we see more cases of pancreatitis? I did highlight the 4 patients that we had where they demonstrated pancreatic recovery, but we're seeing a declining trend in their fecal elastase now that they're on ETI back into the insufficient range. This makes us question, did we stop PERT too early? How frequent should we be monitoring elastase? And how and when do we restart PERT in our patients now that we've stopped it and they're reluctant to restart? And I didn't present this data. However, in conducting this review, we noticed that there's a small cohort of patients on ETI whose elastase values are increasing, but are still pancreatic insufficient, as well as a cohort of patients whose vitamin levels are elevated despite confirmed pancreatic insufficiency. So from our review, we'll be implementing the following monitoring changes for our patients on modulator therapy. We will add vitamin level monitoring at baseline, 6 months, 1 year, then annually and otherwise indicated. And we will also now have a monitoring plan in place for those patients whose elastase levels are increasing, as well as those who demonstrate pancreatic recovery. I want to thank my patients and families for all their samples provided, and thank you to my team for all their support in this review. Thank you all for listening, and do you have any questions?
All right. I think that was a great talk, and I think we just have to be wary of these fecal elastases because I think very variable, especially with ETI and, you know, even those that you showed that went to sort of normal, they were like mildly normal, sort of just in the normal range. So I think this will be really interesting to follow going forward. So thank you.
Thank you.
Zach.
Zach Seller, Stanford. First off, I want to applaud your efforts to get more fecal elastase samples and really be looking at people's pancreatic function after initiation of these drugs. A couple comments. First off, I think you highlight that there are large time gaps between when you've had samples, and so we can't yet really say when people's values are changing, right? And so again, it's another push to say that we need to be doing these assessments and getting these samples at increased frequencies. The other is, I think, to follow up what Nicole just said, is that exocrine pancreatic insufficiency is really a clinical diagnosis, and we often use fecal elastase as part of that diagnosis. But I think your data also highlights that people can be above or below that threshold and may or may not need enzymes. And so all of the other clinical indicators of potential exocrine pancreatic insufficiency are very important. And so I think we can use these fecal elastase values as potentially predictive tools to see whether someone needs enzymes or does not need the enzymes, but it's very important to be following up with them to see if they truly have them, and despite what their fecal elastase is, if they need them, to give them to them. And then we need to label them appropriately, PS or PI, based on their need to have these supplemental enzymes or not, and their other clinical parameters.
Yeah, thank you for the comment. I agree. It's very difficult to know what to do, especially because the elastase levels are fluctuating, but it's really hard for the parents and the patients to understand why they have to restart PERT if they're completely asymptomatic, right? From what we know to be what symptoms of malabsorption would be. Yeah, thank you.
Yeah.
I think we have time for one more question.
All right, I'll try to make it quick then. Mitch Ramsey from Columbus, Ohio. My question was about your patients who had stopped PERT and then their fecal elastase dropped down below 200 or even below 100 and continued to do well off PERT. Now, the focus of this study was really looking at fecal elastase values, and that gives us some insight into the physiology in the pancreas. But I'm wondering if you have any hypothesis or any future directions for explaining why patients continue to do well, even without any, based on the fecal elastase, pancreas enzyme production.
Yeah, I mean, I don't know. I mean, these are the things that I think we're all exploring in the talk this morning. And I mean, the intestinal inflammation and all the changes that we're seeing, I mean, I don't know if that has an effect because, like I said, we're seeing better absorption. We're getting elevated vitamin A, E levels despite like fecal elastase is less than 100. And so there's something changing at the level of the gut, but we don't know what that effect is right now. Yeah, but those are very good points for sure. Thank you.
Thank you.
Thank you so much.
Right. And last but certainly not least, Dr. Michelle Corrado, who is a pediatric fellow in gastroenterology and hepatology and nutrition at Children's Hospital, Colorado.
Thanks. Thank you to Nicole, Michael, and NACFC for the opportunity to speak on this topic today. There are no relationships to disclose related to this presentation. So we're all familiar with the pulmonary manifestations of cystic fibrosis, but there are also pancreatic, gastrointestinal, or GI, and hepatic manifestations, which include pancreatic insufficiency, fat-soluble vitamin deficiency, malnutrition, meconium ileus, and mild to advanced hepatobiliary disease, including hepatic steatosis and hepatic fibrocirrhosis. And as we all know, cystic fibrosis is not just a North American or a European disease. It goes beyond and is truly a global issue. This is a figure from Jonathan Guo's paper in 2022, which highlighted the worldwide rates of diagnosis and effective treatment for cystic fibrosis. The map displays the estimated diagnosed CF patient burden around the world. I do want to point out, though, that the countries in gray don't mean that CF doesn't exist there. It just means we don't have enough cystic fibrosis data to report. So this likely underrepresents the global burden of cystic fibrosis. And there is a growing number of studies that have found how race and ethnicity impact CF outcomes. Bosch and others noted that Asian people with CF have increased rates of pancreatic insufficiency compared to non-Asian people with CF. Wagner found that Hispanic people with CF had more prevalent elevated liver enzymes compared to non-Hispanic white people with CF, especially during the first year of life, and they used the epidemiologic study of CF data. The third study found that Hispanic people with CF have more severe pulmonary disease, which we all know is pulmonary function is one of the main predictors of life expectancy in CF. And using the CF Foundation Patient Registry, Rowe noted that Hispanic people with CF had lower survival probabilities overall. But still, it is unclear how race and ethnicity may affect the prevalence of CF-related GI and hepatic manifestations. So this led to the aim of our study, which was to investigate the prevalence of GI and liver involvement in Hispanic children and adolescents with CF compared to non-Hispanic white children and adolescents with CF at a large pediatric CF center. And we hypothesized that Hispanic people with CF were more likely to have GI and hepatic disease compared to non-Hispanic white children with CF. To test our hypothesis, we utilized a prospective database in place since the onset of newborn screening in Colorado and Wyoming back in 1982. And we conducted an exploratory analysis of all people with CF who were found to have GI or liver manifestations at our center from 1982 to 2022. Hispanic children were matched to non-Hispanic white children based on sex at birth, age under observation, visit frequency, birth cohort, which we did a range of birth dates within plus or minus 5 years, and the use of CFTR modulators. Outcomes were modeled independently with conditional logistic regression to estimate the odds ratio of ever developing each of these outcomes. We'll go by them in groups. Liver outcomes included AST, ALT, GGT, total bilirubin, albumin, and an APRI score, or the AST to platelet ratio index score, which is a serologic marker of cirrhosis. G-tube and feeding outcomes included tube feeds, oral supplementation, cystic fibrosis specific vitamins, and total parental nutrition, or TPN. And growth outcomes included weight for length Z-scores, and height stunt, which defined as a Z-score of less than -1.5, height stunting with a Z-score of less than -2. We also looked at elevated BMI, since there are increased rates of obesity in the Hispanic population, and increased BMI is associated with fatty liver disease. Now for the results. So there were 90 Hispanic and 404 non-Hispanic people with CF who met our inclusion criteria. There was no statistically significant difference between meconium ileus or CF-related diabetes among the two groups. I want to walk through this graph first because there are going to be a few more. So you can see the conditional odds ratio is shown along the x-axis, and various outcomes are along the y-axis. If we're to the right of one, there's an increased odds of having that specific outcome, and if we're to the left, there's a decreased odds of that. And when a line does not cross one, then there is statistical significance. All right, so now that we're oriented, we found that Hispanic people with CF, ages 2 to 20 years old, had an increased conditional odds ratio of ever having a stunted height, which we defined as a Z-score less than -2. And the p-value for this was 0.013. So moving on to our liver findings, while the hepatic outcomes were not statistically significant, the majority of liver outcomes did have a conditional odds ratio greater than 1. And an elevated APRI score, AST, bilirubin, GGT, and ALT are all indicators of increased liver disease. An elevated albumin is inversely associated with liver disease, so it makes sense that albumin would be to the left of this line if Hispanic people with CF have increased liver involvement. So all of these markers indicate that there's potentially more liver involvement in Hispanic people with CF. And this data, though not truly statistically significant, builds the case for us to conduct larger studies since we see trends in this Hispanic cohort of patients. There didn't seem to be a difference in interventions that would account for those different growth outcomes. TPN is not listed on this one because we only had one patient, so we weren't able to include them here. And there was no statistical significance in elevated BMI between the two cohorts. We're going to dive a little deeper, though, into the weight for length scores. So again, let's walk through this slide first. So this is a LOS curve, or a locally estimated scatter plot smoothing curve. Weight for length Z-scores are on the y-axis. There's a dashed line at -1.5, which indicates mild malnutrition. We have the age in months on the x-axis over here. Orange lines are non-Hispanic white patients. Green lines are Hispanic patients. And then these faint lines are individual patients' weight for length. And the thick lines demonstrate that smooth curve for the local regressions of these individuals. So in our study, Hispanic infants with cystic fibrosis were more likely to have mild malnutrition, defined as a Z-score of less than -1.5, which is the dashed line. Particularly for females, there is a difference in weight for length Z-scores. And looking at the individual data below the dashed line, there's a disproportionate difference between Hispanic and non-Hispanic white people with CF. We found that this more commonly occurred in the first year of life, especially in the first 6 months of life. But luckily, all Hispanic infants with malnutrition recovered by 24 months of life. So limitations of this study include that this was a single-center retrospective data source that revolves around clinically recorded data. So there may be some variations in when and if GI and hepatic outcomes were assessed. But although this was a relatively small cohort, it's probably one of the largest cohorts where this has been examined. Another strength of our study is the longer duration of about 40 years. And still, this was a single-center pilot study to help us justify the need to do a multi-center study. So moving on to our conclusions and summary of findings, stunted height in childhood, ages 2 to 20 years old, and low weight for length in infancy, 0 to 2 years old, were more prevalent in Hispanic people with CF. And in this cohort, although there was no statistically significant difference in most GI and hepatic outcomes, there appears to be a trend towards increased hepatic outcomes in Hispanic people with CF. And this question needs to be examined at a larger cohort. Obesity and meconium ileus were not more prevalent at our center's CF Hispanic population. So since there are established relationships between early childhood growth, both in weight and in height, and later lung function, these growth differences may explain those lung function disparities that have been previously reported in Hispanic people with CF. And we should pay closer attention to the growth in the first 2 years of life, especially in the Hispanic cohort of patients. Future studies are warranted to examine the liver involvement in a larger cohort of Hispanic people with CF. And further, we need to assess the underlying mechanisms or causes of these GI and hepatic outcomes so that we can establish interventions to ultimately improve outcomes in Hispanic children with CF. I'd like to thank first all of the patients and families at our center, as well as the CFF, for my funding during my first and second year of clinical fellowship, my mentors at the Colorado Breathing Institute, especially Dr. Sagel, and at the Colorado Digestive Health Institute, especially Dr. Narkowitz and Dr. Jake Mark, who's one of our Digest Fellows, as well as the rest of our entire team, including Dave Johnson, Ellen Hanley, and Brandy Wagner. Are there any questions?
That was really interesting. I'm Katie Larsnody. I'm an endocrinologist from the University of Iowa, pediatric. And I was, of course, very struck by the height data that you had there. You probably don't have this, but do you have any information on the family heights? Height is like 99.2% genetic, and Hispanic populations are extremely diverse. So if you have like a high population of Guatemalans, they are typically very short. So do you have any of that information, because that would potentially confound your findings?
That's a really great point. We do not have like the mid-parental height or those growth curves. A lot of this data too. So we started in the 1980s. So EMR did not exist back then. So we don't have all of that data. We are starting to look into thinking about height and pulm function. We're looking at the data for PFTs for the patient study in the study. That's an excellent point.
The other question is, since you had such good long-term data, do you have final adult heights for those?
That is something that we're working on as well.
Okay, because that could be informative too. Mm-hmm. Wonderful talk. Thank you.
Absolutely. Thank you.
Hi, my name is Rosara Bass. I'm a gastroenterologist at the Children's Hospital of Philadelphia. That was a great talk. I was wondering if you had any information on age at diagnosis for the two populations?
Yes. So we did, and I can pull up this slide on our matching. This is a slide that kind of just breaks down how we matched all of our patients, and we did include age at diagnosis. For the most part, kids were younger in our group just because of the advent of the newborn screening test. But there are, some people who may have been diagnosed a little bit later. So just to orient you here, the x-axis are ages in years. Orange is Hispanic, green is non-Hispanic, white. The dots are clinic visits, and then these horizontal blue lines are years on modulator therapy. So we tried to match to our very best 5-to-1. And you can see that there's, it kind of looks pretty good. Our statistician did an excellent job, but this would be an example of to answer your question, where there were some kids who didn't present exactly at birth, and we tried our best to match those children when they came to our hospital, whether they moved from someone else or were like later diagnosis.
Thanks so much.
Mm-hmm.
Oh, nice talk. My name is Raul. I'm from University of Sonora in Mexico. So one of the comments that I have is, some of the measurements like the C-scores and the cutoff values, they have, at least in Mexico, they're moved, so they're corrected for Mexican population. So they might be available out there, so you can have a more accurate measurement for
That's a really
each
great
population.
Yes.
And a question: have you seen, or do you have information about the mutations these Hispanic populations they have? Are they delta or they're different?
Yes, great question. And thank you for that point as well. So we did look to see if we could match against the different genetic mutations, but there was so much variability that we wouldn't have enough good numbers to do that. So we didn't do a deeper dive into it, but we started to look into those different mutations.
Thanks.
Dan Leung from Houston. Great job. Really enjoyed your talk. Because this was a retrospective study, I don't know if you have access to feeding type or caloric density of the formulas, or whether or not these patients were exclusively breastfed, and whether or not the form of the diet contributed to the stunting, particularly within the first 2 years.
Great point. So when we looked at our outcomes for our GI growth outcomes, we just looked to see if they were on some sort of oral supplementation or not. We didn't look specifically to see if they were breastfeeding versus formula feeding in the data set that we had. I would need to look back and see if that's available. But that's a great point to think about those first couple of years of life, and could potentially offer some interventions down the road.
Yeah, the bonus study suggests that type of feeding probably is not the difference within the first 12 months of life, but I was just curious whether or not there was any barriers to access to supplementation for those patients who may have been diagnosed a little bit later.
Absolutely, yes. Thanks.
Great. Thank you.
Thank you.
All right. Thank you, everyone. These were really thought-provoking talks. I think Michael, are we able to get back to Zoom? Michael wanted to say a few words if we can. If not, yes, we can hear you.
I wanted to, on behalf of Nicole and myself, to thank everybody, to thank the speaker. It really was great session, great talks. And thank you for keeping the time, and very good questions from the audience. And I just wanted to tell everybody here to have a great meeting and enjoy the rest of the meeting. So, and we'll see you next year with more you guys stuff. Thanks very much.